All right. Well, good morning. My name is Jonathan Grauer. I'm editor-in-chief of North American Spine Society Journal. And it's a real honor for me this morning to be able to talk with authors from a recent paper that was called, Does Conflict of Interest Affect the Reported Fusion Rates of Bone Graft Substitutes and Extenders? Maybe I can ask you two just to make introductions of yourselves.
Yes. Hello. Hi, everyone. I'm Yupo Lee. I'm currently a clinical professor at the University of California, Irvine.
Hi, my name is Joshua Lee, and I'm currently helping out at UCI doing some research this summer.
Fantastic. And, you know, like I talked to you in getting ready for this podcast, I was really fascinated by your study. I think it's a great study, and it's really a wonderful opportunity to be able to talk about it. Maybe as an introduction, you can just tell us a little bit about the study and your ideas behind doing it and what you did.
Okay. Yeah. So, you know, the paper itself is somewhat simple. It's basically what we're looking at is iliac crest bone graft, as we all know, is the gold standard when it comes to bone graft for lumbar fusions. And so one of the things that have been noticed is that since there's a limited supply, using bone graft extenders such as demineralized bone matrix or a calcium-based substitute has become increasingly popular. But one of the things that we've noticed there are concerns about, I guess, when you use these, when there's commercial products, is that when a researcher publishes on the fusion rates, is that there's always the risk for bias, especially if there's a consulting agreement potentially, or if there's some potential gain. And so what we wanted to look at specifically is that when there was a reported conflict of interest, was there a difference in fusion rates in the papers that had conflict of interest versus those that did not? And specifically, we were looking at lumbar fusions, 1 to 2 level.
And how many papers about did you look at? Were you able to find a substantial body of work to review?
Yeah. We looked at around 2,000 studies, 1928 to be specific, and we included 86 in the study. And fusion rates, actually, there's a wide range. It actually could be, it was anywhere from 4 to 100%. And yeah, there are 24 studies with a potential conflict of interest and 62 with no conflict of interest. And the average for all these studies was 84.63 with the standard deviation of 18.33. Actually, surprisingly, in cases with a conflict of interest, the reported fusion rates was actually lower than if there was not a conflict of interest. For cases where there was a conflict of interest, the fusion rates were 80.93%, while when there was not a conflict of interest, the fusion rates were 63.6%, and this is statistically significant, was not statistically significant. And when there was a CT scan involved, that reduced the reported fusion rates to 79.8 versus like 87.9% without a CT. And then when there was like an independent reviewer as well, the reported fusion rates dropped from 85.63 to 82.61%.
Great. One of the things that just caught my ear as you were talking was that you did narrow down the population you were looking at quite a bit. Any kind of question or concern about about getting a fair sampling of that? Like, what were most of them not included for? Were they just not relevant to the question being asked, or kind of what was kind of, how did you get to that group of studies that you did evaluate?
That's a great question. So the first criteria specifically was looking at what that we're looking at is 1 to 2 level fusions in the lumbar spine, because there was a fair number thoracolumbar. There were a fair number also cervical. And then so we specifically selected the lumbar 1 to 2 level. And what we were looking at was also degenerative conditions, which was degenerative spondylolisthesis, and also in cases of spondylosis and stenosis. So if it was trauma, tumor, infection, those were eliminated. And so that really eliminated a fair number of papers. And then also, one of the things that we also noted was there were a fair number of papers which had less than 25 patients included in the study. And also in those cases, when the sampling size was less than 25, those were also eliminated. And that's how we got down to specifically that specific number.
And it sounds like, I mean, the primary finding is that we shouldn't necessarily be worried if there is some involvement of authors with the company whose product they're evaluating. That sound fair of a kind of a summation for what you're suggesting with this study?
Yeah, and also one main thing to also emphasize is that this is in the presence of like CT scans to get accurate, more high resolution, I guess, scans, as well as an independent review to have more stringent, the categories or when evaluating these studies.
Correct. Because what's interesting and what's one of the things that is, as you know, Dr. Grauer, trying to get funding, I think nowadays to do any kind of research is becoming really, really, really difficult. And if we are to advance in our technology, advance in science, where does the funding come from? When you look at some of the biggest advancements that we've had in spine surgery, right? You think about like fusion substitutes, motion preservation devices, and now navigation. These are all things that have been funded by industry. And when you think of, in terms of funding support, a lot of the funding came from industry. So one of the things that has become really important is trying to decide that if industry does support research, does it affect the findings? And as Joshua was saying, is that one of the things that we noted is that in all of the studies that were supported by industry, all of them had CTs as a criteria for fusions except for 3. And in those 3, but even in those 3, they had independent reviews with flexion extension x-rays. So one of the things that we noticed was that, and as Joshua was saying, is that when you use the CT, the fusion rates were 79 versus 87% when there was no CT. So having the CT itself, so higher resolution imaging really made a big difference in terms of determining if there was a fusion or not. And that almost kind of helps eliminate some of the bias. But then another way to eliminate your own bias is not have the original surgeon evaluate their own images, because that's also potential bias, because as we all know, we always hope for the best, right, for our patients. And so there's always just, some surgeon bias in the sense that, it's like, that is fused. But, so what's interesting is that even the surgeons who had no interest, their reported fusion rates were higher just because I guess there's some bias in your own work.
Good. So, to think about this from the reader's perspective, how would you like them to think about studies they read or products that they use? Like what would be the take home you want to leave them with?
Yeah. So the take home is that, in regards to what's interesting also, and that we'd like to bring up is that there were a fair number of papers in which iliac crest was also used as a comparison graft, as a control. What's interesting is that the fusion rates for those was actually 83%. And what's also good to know is that in a general review of the literature, right, iliac crest bone graft generally has a fusion rate of somewhere between 80 and 90%. So we know that it seems like there is some accuracy also across the board in terms of the fusion rates itself. What's interesting to note is that one of the other interesting thing is that the criteria was that laminectomy bone was also used in the majority of studies with demised bone matrix, as well as the calcium-based substitute. So what's interesting to note is that when the demised bone matrix with the laminectomy bone, that's the fusion rates are comparable to iliac crest graft, and same as the calcium-based substitutes. So using that laminectomy bone is also is really helpful in terms of improving your fusion rates, and almost makes it comparable to iliac crest graft. What's interesting is that, and this is also very consistent with the studies on laminectomy bone as well that have been out there. When there were a couple of Japanese studies that looked at that, where those fusion rates were also in the high 80s. So what's nice is that the findings in these studies are actually fairly consistent with the literature. That's
great. Good. Well, anything else you'd like to kind of share with those listening?
Yeah. Anything you want to say?
No. I just want to say,
So one of the things that I don't think we emphasized enough in the paper, but we'd like to bring up is that there are a couple of things. Actually, if for those people who do use the demobilized bone matrix and the calcium-based substitutes, in the papers that did not use laminectomy bone, one of the things that we noticed was that the fusion rates were at least 10 to 20% lower. So if you're, so I think that, using the laminectomy bone and morselizing that with a mill, it really is helpful in terms of getting a good fusion. So that's something that, I hope that that's a pearl that a lot of the listeners will take, because, we've kind of poo-pooed laminectomy bone in the past, but I think over the years with the, just milling it and really getting the tissue off of that really helps, and that can be really good for cost saving. The other thing that was notable was that with the use of flexion extension X-rays with an independent reviewer, the fusion rates there were also nearly comparable to a CT quality. So, once again, flexion extension X-rays, I think, may also have a role as part of advanced imaging. But in that case, having an independent reviewer, if you're going to use flexion extension, can really, help delineate and potentially eliminate bias.
Wonderful. Well, I will absolutely be thinking of your study next time I read a study about bone graft products, even other industry-funded things. I really think this is kind of helpful to have in mind. And like you say, funding can be tough, and kind of understanding how to interpret funding sources and how that might interplay with how you interpret and the messages you take from papers is really helpful. So I really appreciate the work you've done.
Thank you so much.
Thank you.
Great. And thanks for joining for this podcast.